with patients' parents. They didn't tell them exactly what they were putting in their child, and the devices that he was using were never approved for children. They were approved for adults, and we're not even honestly sure whether he was a doctor. If you were a parent, would you feel okay turning your kid over to surgery while this doctor didn't do a timeout, not only neglected the timeout, but neglected it because they were on their AirPods in a meeting for their other job? I cannot not speak up because, like I said, these are vulnerable populations.
When you're ready, can we start at the beginning? What first led you into nursing?
So my story kind of starts, I think like everybody's story starts, you have a calling. Most nurses don't do this job unless they feel they have a calling. And what they don't teach you in nursing school, they make you take an ethics class. Some colleges have it woven into every class, so it's a little more subtle, but they kind of teach you what to do about death and dying, about the patient being of age, requesting to be comfortable, what would you do in that situation, but they never stress what do you do in situations where you see purposeful harm. In the last 15 years, I would say that medicine in general in the healthcare field has shifted from what used to be very curative, Gene Watson kind of care, where compassion, love, treating the patient holistically was the focus, to more of monetary incentives. And we've kind of seen that a lot recently with even a CEO. And they don't really explain what do you do. When you go to the hospital, your orientation, you were told that, you're supposed to call the safety line. They give you an anonymous line. They give you this chief safety officer's number, but they don't ever talk about what happens when you get pushback. They don't talk about the code of silence and how real that is. So, my initial experience was a lot of joy. It was really centered about the patient. And then after a few years, you kind of get ingrained in the politics, the hierarchy, the structure. And sometimes you run into an unfortunate situation, such that I ran into with a doctor at a children's hospital who was very condescending, didn't have orders placed when the patient came up from surgery, which is a big no-no. The Joint Commission would throw a fit. And I knew something was off, I knew something wasn't right, but I didn't know what to do about it. I didn't know who to report it to. When I asked my supervisor, why this doctor had a badge before, the residents wrote his orders, he came up to the floor, he would answer phone calls, and now all of a sudden he has no badge, residents can't write orders, we're not allowed to tell the nurse practitioner anything about the patients. And it's like, well, but why? Why are all these things changing? This isn't right. I was told not to worry about it, to just listen to what they said to do and do my job. And that didn't sit well with me. One of the patients in particular came up and had an infection, had a fever, was in all kinds of pain and had absolutely no medications, not even Tylenol. So it was like, okay, well, call the doctor. It took him 2.5 hours to respond to me. That's not appropriate. It's not appropriate that it came up without any orders written, first of all, but it's really not appropriate that it takes that long for a callback. When he finally called back, he was like, okay, give him 325 milligrams of Tylenol. When I clarified the weight again and the age of the patient, I was like, are you sure you want to order 325 milligrams of Tylenol? Because most nurses know that's not therapeutic. Even my own mom would know that a 12-year-old child would have more than 325 milligrams of Tylenol every 6 hours. He got angry and said, how much do you think I should order him. Well, first of all, we could talk about the problems with that because I'm not a doctor and that's not in the nurse's scope of practice. So I didn't tell him what he should do, but I kindly suggested that he could probably have at least 650 milligrams every 4 to 6 hours, but the 325 wouldn't touch his fever, much less his pain. And I was like, well, what are we going to do about his pain? And he has a fever. Do you want blood cultures? And what do you want to do about this? And he got irritated before I even could get to there and hung up the phone on me. And we didn't even do the proper verbal write down, read back process. So therefore, I was expected to enter his orders in the computer, and we were given permission to do that, which was against really hospital policy. The policy stated that you either needed to be in the trauma bay or in the OR to be taking verbal orders and placing them in the computer for the doctors, because that's why we had the residents. We were a teaching hospital, and it's a protection for the patient's safety. Children are very easily overdosed. They're dosed based upon their weight. It's not a one-size-fits-all. So if I did nothing, he wasn't calling me back. Am I going to wait another hour and a half? Or do I put the 650 that I know that he can have in, even though he never followed the proper procedure? So, I mean, I can't leave my patient suffer, so I risked it on my own license and my own scope of practice to put the 650 of Tylenol in so I could at least get his fever down. But he could have had a surgical site infection, which is a big no-no for the Joint Commission. And here I am at 2.5 years out of my nursing practice, and even I know better than 325. So it was really disheartening to me when I spoke up. I was just told, just do your job, don't worry about it. And then I started to hear the rumors in the hospital that anytime a nurse got put underneath, any questions were brought up, that nurse got kicked out, another nurse got put in. I had later, and by later I mean probably 2 years after the fact, found out that not just the nurses underneath him spoke up and got removed, but also the doctors, his own peers who knew what I didn't know, that a spinal surgery under a 30% curvature, you have to do PT first. You don't automatically offer surgery or even suggest surgery. You try braces. There's a multiple number of things that is protocol for you to do to keep patients safe, to follow the guidelines of the doctors, and to guide their practice, just like nurses have their own policies and guidelines. And the doctors pushed up, and when the doctors pushed up, they also got silenced. And they went to the appropriate people. They went to the safety officer. They went to the administration underneath him, both doctor and general, to the point where CEO, COO, CNO were all well aware of what was going on. So he ended up, I found out many years later, losing his hospital privileges, which is why he didn't have the badge, which is also why the residents could not write orders for him. And we're not even honestly sure whether he was a doctor. He lied about the dates and times of his supposed residencies. We don't know if he finished. Obviously, when he moved to America, he finished his residency here, but we're not really sure he ever finished there. And he definitely, in addition to not performing and being aggressive in surgeries, he also did Medicare and Medicaid fraud. So at the time, he worked with a company called, and they sell doctors that do surgeries, devices, so that they can do their surgeries. And he didn't disclose that with the hospital. And they did eventually know about it. They never got informed consent from the patient's parents. They didn't tell them exactly what they were putting in their child. And the devices that he was using were never approved for children. They were approved for adults. He also did surgery at adult hospitals, but that gave him access to the devices that he was using in his surgeries, but they have to be approved for the pediatric population, and usually they have to go through adults to make sure it's safe before they trial them in kids. He didn't even wait for that. He just moved to implanting those in the children, and they would bill it under miscellaneous. He didn't get told that by the doctor or the hospital that they were implanting said device. So when you were signing consent for surgery, you weren't really signing consent, because true informed consent is knowing what they're using, what they're doing, how long it's going to take, all the risks and benefits. And then after full knowledge, that signature means informed consent. So I didn't know all this. This is what I found out after the fact. After the doctor lost hospital privileges, he continued to rent out the OR. He continued to make money, and the hospital made money, and they allowed him to rent out the OR knowing he was putting these devices in.
So you're saying that he was allowed to continue to operate and he didn't have hospital privileges?
Correct. They did that so that it didn't come back on them. They could say, well, he has his own practice. We just rent out the OR to him, so therefore we don't know anything about that.
I'm going to speculate based on what you've shared with me that the hospitals in each year, whether it was gross or net, more than 1 million. But it's highly unusual that a hospital, I've worked in hospitals that might have looked the other way a little bit on surgical volume or, OR, post-op complication rates and infections and maybe standards of care. But they didn't look the other way and allow surgeons to operate that didn't have privileges. So that's highly unusual. How long did you work there where this was going on and you found out afterwards that he was operating without privileges?
He lost all privileges. So he eventually was gone from the hospital. He moved to a different hospital in the area. It started all over again. But people there were also aware. They knew he worked for his previous employer. They knew there were issues. There were issues there that also got silenced. It was a pattern.
So when you say issues were there, aside from what you described in the post-op period when the patients came to the floor post-operatively for care, were there reports of complications? And that's what people were looking the other way on in the code of silence in the various hospitals. Were there complications with the patients, both adult and pediatric?
Yeah, there were a high rate of post-operative infections. There were a lot of pain that went unaddressed, mostly because they didn't have orders for pain medicine and mostly because it took so long to get the orders. But even after you would get an order, if that pain medicine wasn't working and you had to call back, there was several delays in care, higher than normal infection rates. So, yeah, the doctor ended up testifying, and what do? You don't testify. You have an option of going to jail, perhaps, if they find out you're not telling the truth. You tell the truth, and you get blackballed by your own institution that you work for, your own employer. And this happens a lot. They blackballed him in a board meeting, told him to be quiet when he went ahead and testified. Then they did false peer review against him. They use peer review as a way to punish people if they do wrong. It's not supposed to be used for punishment purposes, but that's how they typically silence you. They do it to nurses, not just doctors. It was kind of done to me. I mean, they'll take things that they would never call you in for and pick you apart, make you feel like you're 2 inches big and you've really screwed up. And it's like, well, actually, yes, I was late with this medication and this blood sugar, but this patient was having respiratory issues, which ABC, you're talking about circulation. Yes, nobody's perfect. There's no nurse, there's no doctor that's perfect. However, there's a huge difference in advocating for what needs to happen for the patient's benefit and causing purposeful harm. And even making a mistake that does cause some minimal harm. I mean, this is serious harm. You're talking about kids that die, adults that die, some that are paralyzed and can never walk again, and Medicare, Medicaid fraud, which is, huge. So, I mean, it's not just something to keep quiet about because it has very legal ramifications. So it's not just an ethical wrong, it's like a legal, like this is legally wrong. I mean, how do you sleep at night? That's what I want to know.
We can't answer that because you don't know. What the motivation is there other than the surgeon was likely incentivized by volume and was highly compensated. The hospital, on the other hand, aside from being, criminal, it's unethical. And the fact that so many people knew in all of the appropriate positions and knew better, the thing that all of it is shocking and sad. I'd be lying if I said I was shocked because I'm aware of incidences that have happened over the course of even my career, but I'm not familiar with hospitals that let physicians care for patients, including perform surgeries, and they don't have privileges, meaning that it's one thing for a physician to be hired, and they come into the community, their private practice, and they're going through the credentialing process, which can take very long. That's one thing. But to have them terminated for cause and then allow a surgeon to, that's highly unusual.
Well, I thought so too, which is why I left, in addition to, growth and utilizing my degree. But then I went to another hospital, and it wasn't anything quite to that scale. I don't know that I'll ever see that again in my career. I hope to God not. But I feel like you should feel comfortable speaking up, and I can't just be quiet. And I went to another hospital where there was another doctor that replaced a division chief because partly they wanted to say that clinic was bad, they were getting lots of complaints. That may have been true. I'm not sure that doctor needed to be fired. However, when you look at somebody that may be not performing the way that you need them to, and you're trying to improve your clinic, you don't want the complaints, you think new leadership is due, you have to be careful about who you hire, and you should be open to hearing complaints when things are not going correctly. So the doctor was replaced. They brought a new doctor in. They were not able to keep up with the surgeries when they lost that doctor because it was a division chief, and they replaced them with another doctor who was more rough in surgeries, caused more bleeding, more pain complaints from the patients, and then wasn't doing timeouts. And I echoed that up and got let go. And I politely, wasn't the only nurse that saw this. I was probably the only nurse that was willing to speak up, but a lot of nurses in this hospital were particularly young. Due to the geographic location of this hospital, it was difficult with competition to get nurses that were tenured with experience and that had seen things like this before, and they were not comfortable speaking up. And I had heard the complaints from the OR nurses, from the clinic nurses that were in the OR educating with the doctors, and not only did they not do a timeout, but they were doing something that probably should not have been done. It's not probably shouldn't have, it just shouldn't have been done. I mean, if you were a parent, would you feel okay turning your kid over to surgery while this doctor didn't do a timeout, not only neglected a timeout, but neglected it because they were on their AirPods in a meeting for their other job? I cannot not speak up because, like I said, these are vulnerable populations. These are people that can't speak up for themselves. And I looked at the CNO in the face and I said, listen, I said, this is what's going on. I said, you need to check into this. And this came in the setting of the Joint Commission already being there and finding that the instruments were not sterilized properly, that they had been warned a time before to remove surgical tape because it's no longer considered sterile, to find another way to sterilize your instrument and identify them. And they did a half job. They left tape on half of the instruments and the other half they didn't rotate out, and they etched them so you could identify them by the etching, which is great, but they didn't finish the process. So you've already got one red flag here. Joint Commission's coming back, and if they come back and find something else, then the hospital gets taken to CMS, and they risk losing their funding, right? Their Medicaid, Medicare funding. So I'm letting the chief nursing officer know this, not only for the protection of the patients, but so they don't get in further trouble.
For people listening to this, on what grounds? What was the cause for termination? Did you get notice, or were you literally fired?
I did not get notice. They should have owed me 2 weeks notice, actually. That's legality I found out after the fact. But I was fired, Johnny on the spot. I was told that this would be my last day. And the reason that they gave me was that I did not follow the values of the hospital.
But the institution terminated you. Sometimes organizations terminate you and they will say there's a reduction force, or they'll say we're restructuring, we have a layoff. They've basically terminated you for cause. You didn't pursue any kind of appeal or any kind of legal review because they had worn you down and you had gone through this. Even though you weren't terminated for the organization, you left.
I did not pursue any additional legal matters, any arguments at all whatsoever, because it was not an environment I wanted to stay in. If I can come to you and your values are the patient is the center of your care, you are to protect them, safety, quality, we deliver that. We expect you to be honest. We expect you to report unsafe things. So I didn't use the appropriate channel probably because I didn't call the hotline anonymously, but I still used a channel that I felt comfortable with because I knew the CNO, because we had an established relationship. And because of my given history, I knew that if I escalated it to a hotline, nobody would address it. I wanted to do it not anonymously because, first of all, the whistleblower law doesn't protect you if you do it anonymously, so don't do it that way. And number two, I wanted to look that person in the face and I was holding leadership accountable. I knew you knew because I knew I told you. And I wanted to see if you would do the ethical thing. And when I knew that you wouldn't, or most likely wouldn't, I haven't followed up, like I said, to be honest, I then knew that this was not the place that I needed to be. I left before and I'll leave again, and I've been told, pediatrics is a small world, the medical field is a small world. Somebody will hire me, I'll find a job somewhere. With the degree of education that I have, especially now that we're considered non-professional degrees, it's going to be harder for people to get that kind of degree, and we're already in a shortage. I will find a job somewhere. And I still had this altruistic optimism. Maybe it's toxic positivity. I'm going to find something better because not every place is like this. Surely it can't be. So that led me to look for another job. I'm at a home health care company now, and I have so much autonomy. I don't have to worry about dealing with unethical doctors, administration, and healthcare leaders who ignore or silence you because I can't be fired for speaking up.